Ari, can you give me a joint that has 2 degrees of freedom?
2 degrees of freedom?
What is, if I said a joint has 2 degrees of freedom, what does that mean to you?
You can move in 2 directions.
It can move in 2 planes through 2 axes, right? So, out of what we talked about the other day, can you name a joint? Because I didn't give you the names of them, but and if you can't remember them, it's okay. But Glenn Humeral, does anybody agree? Does everybody agree?
No.
Okay, so how many degrees of freedom does a Glenn Humeral joint?
3.
3. Okay. Why is it 3 instead of 2? Because you said a joint that has 2 degrees of freedom moves through 2 planes and 2 axes, right? The Glenn Humeral joint moves through 3 planes and 3 axes. So can anybody give me a joint that has 2 degrees of freedom?
Metacarpal pharyngeal.
Metacarpal phalangeal. So that means when the metacarpal meets or joins or articulates with the phalanx, we have flexion, extension, and adduction, right? We also have 2 degrees of freedom in the thumb joint, where we have, can somebody show me flexion and extension? Chris, can you show me flexion and extension of the thumb? Put your hand up in the air like this.
Okay.
Show me flexion and extension.
Well, it actually be in a different plane than it normally would for all the other joints. This is flexion, this is extension.
And adduction?
Would be this way and this way, which
Good.
is
So
the
what
opposite.
plane is flexion and extension in of the thumb?
For the thumb, that would be not the sagittal, not the transverse. That would be the frontal plane.
Frontal plane.
The other one.
Right. Frontal plane, and since planes and axes are perpendicular to one another, it's frontal plane through a
Sagittal axis.
sagittal axis. Good. We good with that? What is the difference between supination and pronation of the foot? Not Casey. Casey? No. Corey? No. Corey. Corey. Sorry. You're in the other lab, so sorry. Corey, what's the difference between supination and pronation of the foot? First of all, what joint? Those movements occur in what joint? Andrew. Okay, Andrew, what joint?
Mid-tarsal joint?
Tarsal joint. So, going back to Addie over there, what is supination of the foot? So tell me in terms of movements that are occurring, or remember we said that there's a lot of planes, there's axes X, Y, and there's a Z axis also on the foot, which becomes too complicated for this course. But there's component motions associated with that supination from that mid-tarsal joint. So there's 3 motions actually that make up that one motion. And Aldridge is biting at the bit there because he knows. So Aldridge, tell me what supination is.
Supination is like when you inversion of the ankle.
Oh, no. There's 3 motions associated with supination of the foot.
Right.
What are they?
Plantar flexion, adduction, and
Plantar
inversion.
flexion, adduction, and inversion. Right? And what is dorsiflexion? The other,
Dorsiflexion.
which
Dorsiflexion,
is
eversion,
eversion, dorsiflexion, and abduction. Right? What does a long bone? Can you tell me the structure of a long bone, or can you tell me the structure every diarthroidal or synovial joint has? What do they have in common?
Steve, can you hear me?
Anytime you have a diarthroidal joint, you have these components in the diarthroidal joint. Can you give me them, Chris?
Well, they're all going to have a joint capsule, synovial capsule. They're all going to have freedom of motion. And let's see. Well, the bones aren't going to actually touch. I guess that's the same as telling you that they're contained within a capsule.
Okay, so you told me it had a capsule, you told me it had synovial fluid, you told me it had synovial lining.
Then there's a synovial membrane within
Synovial
that capsule.
membrane, okay.
And there's a fibrous tissue on the outside of the capsule. Steve, do you hear me? The surfaces of the bones are covered in hyaline cartilage.
Hyaline cartilage, surface of the bones.
Or articular cartilage.
Andrew?
Steve, I'm not sure if you can hear me, but I can.
Ligaments? Yeah, so all these are all, and, Melissa?
I
Lois.
Okay, I just sent you an invitation to a Zoom meeting to your Rutgers email account. You should be able to just open that
Diaphysis,
link. You should be able to-
diaphysis, and epiphysis.
I just did.
One where we're having structural growth of the bone in a longitudinal and as well as a horizontal direction. Okay. All right. Can we name a joint? Chris, you got a
Well,
question?
I can name a joint, but I have a question about the metaphysis. Did you say metaphysis or metaphysis?
Metastasis.
Okay, metaphysis. It's hard. How do you like separate when the epiphysis begins and when the metaphysis ends? I'm not sure. Like.
There's a flared area and it's also where the spongy bone changes or the medullary canal changes. And then we have a cartilage formation down at the bottom in the person that has long growing bone. But one's like the neck and one is the head.
Okay.
What was my other question? So can anybody give me a name of a joint? Any joint. Name a joint. Atlanto-occipital joint. Atlanto-occipital joint, but what, remember we said that
Occipital
the
is-
appropriate way to name them is from superior to inferior. So, atlanto-occipital would be the same as occipital-atlantal, right?
Yeah.
That's the correct way to say it. We started to talk about joints, we said what a joint was, we said there's syndesmosis, synarthrosis, kyphosis, diarthrosis, and most of the joints that we have in the body are diarthrosis. We called a hinge joint a ginglymus joint, it's the same thing. A hinge joint is one degree of freedom, which means that it's motion through, motion through one plane, one axis. So, give an example of a hinge joint would be elbow flexion, elbow extension, knee flexion, extension. We're going to say knee flexion, extension for now, calling it a hinge joint, but we'll know later on that there are some rotatory motions associated with the knee, especially, but that's associated with ACL and PCL. We have lateral movements and medial movements of the knee itself. I won't put this up here because, you have this. Pivot joint, we said, is a rotational joint, and the pivot joints we talked about were AA. I'm not so sure about next Thursday, so don't stress about next Thursday because I'm not covering what I needed to.
For the exam.
The reason,
So
so don't stress about it because
So should we
I know you had sent me an email. When you guys send me emails, I take them very seriously and I contact people immediately. It has taken him a while to get back to me. I'm still waiting to get back for the librarian here, although she said the first week of October she will give us a Zoom call. I'm wondering if that's best to do on as a group. I'm not sure because I just want to make sure that it gets done and we don't waste time. Yes.
So we did ask the Rutgers guy if there were any meeting
You did
areas.
ask about rooms. I asked the dean that the day that you asked me that question. I asked her again. She said the person that's supposed to tell her has been out. And I asked her, and I also asked her to stop in here if she knew the answer to that. So if I don't get an answer to that by the end of the day, I will get an answer to that and I will send you an email. Okay? So as far as, and whenever I say you will be responsible for the material up to the day of, that includes Tuesday. So if we had an exam on Thursday next, that would include Tuesday's information. Because I expect you all to be adult enough and be studying as we go and not waiting till the last minute or the day before to review this material and then say, well, how do you expect me to review all this material that you just gave me today when I have all this other material from 2 weeks ago? Okay? So I think I covered those questions, right? All right.
The only other thing was how much of the insurance PowerPoint are we responsible for?
The insurance PowerPoint, I will tell you, I started making up the test right now. There's 2 questions on 2 scenarios. On Miss So-and-so went to a facility and the ultrasound didn't work, but they said, don't worry about it, you're going to feel it anyway, et cetera, et cetera. What are the ethical principles that are violated? That's about it. Okay, so it's based on that. just to see if you understand with the ethical principles and the scenarios.
So
Yes.
I know you said don't stress about it, but should we like just
Don't
prep, like
stress
there's
for
gonna
next
be a
Thursday. I
test?
can't give it next Thursday. I haven't covered what I need to cover.
Okay, so no
Okay.
test next Thursday?
No test next
Plan on
Thursday.
it the following Tuesday?
Yes, because Tuesday and Thursday, all I want to do is lecture, yes.
We don't have to know the difference between like PPO and all that stuff for the insurance, mainly just ethical questions.
Yes. Okay? All right, so, yes.
Like benevolence and,
Well, yes, benevolence, because that's a scenario, right?
Yes.
Have you violated benevolence? Have you violated, and is it, when you look at our code of ethics, what does it come under? You know, I don't expect you to memorize verbatim what the code of ethics are, but I expect you to have an idea. Okay, similar to what we discussed in class.
And then the due date for the paper is October 6th?
Yes, because this is easy enough to find. I also do think I still want to give you a paper, I do. I think I want to give you a paper that's due after Thanksgiving.
That's a
I
group,
do.
right?
A group paper, yeah. So you will have more information, and you, Steve, he's a great guy. I mean, you can email him anytime and say, this is what I'm looking for, can you help me? All right, so APA style, anything, you know, there's stuff that he can help you with, yes.
I didn't hear your response about the specific types of insurance, like HMO, PPO, we should know that stuff?
No,
No.
that's not gonna be on it.
Just like ethic-based questions on insurance.
Yeah, right. So we talked about what the types of joints, now, we also started talking about the joint structure, and we said there's bursa. And I'm just following, I'm not putting this up here, you have it in, I'm going directly by your PowerPoints. So what is a bursa? It's a fluid-filled sac. Generally, what you see a bursa, and you see a bursa. In a cadaver, the bursa is flat because it's not full of synovium. So it's located in areas of excess friction to protect the tendon that's going over the bone, right? So you can think of, those of you who have rotator cuff problems, you can think of the fact that the rotator cuff comes around, and then there's this humongous deltoid. Some of you have great large deltoids that sit right here in the cuff of the muscle. Now this muscle has a subdeltoid bursa to protect the deltoid from the tendons of the deltoid and the muscle itself from going over the acromion and going over the deltoid tuberosity. So we have subacromial bursa, we have subdeltoid bursa, we have bursa everywhere. We have acquired bursa as well as anatomical bursa. So think of an acquired bursa. Your book gives an example of one that's in your finger. So students now, it's very different. You probably have carpal tunnel and maybe you have ulnar nerve dysfunction. Those of you who do a lot of writing, which I still encourage because I think this is baloney for learning. I really do. I think this is baloney. You know why this is baloney? Because you never cross midline. Never cross midline. So you have a corpus callosum where you have neuronal complements of neurons going from the right to the left side of the brain. Never happens. That's why you have all these kids out there with ADD. You know, you used to be able to hit a ball, play hopscotch, do these kind of things. Now kids go home and do video games, you know. So I am a firm believer of writing your notes and doing things like you do. Okay, so, but a bursa, an acquired bursa, which is just the pen rubbing on the thumb. Another example of an acquired bursa is a pump bump. Women, you know what I'm talking about when you wear their high heels and they're a little too loose. And you start walking, what happens? They flop in the back. So then over time you get a bump there and it's acquired bursa to protect that Achilles tendon. That's known as a pump bump. So you can have a bursa that's acquired, you could also have a bursa that's anatomical. Okay? Acquired and natural. Students bursa, pump bump. Tendon, what's a tendon? What does a tendon attach? Bone to muscle. What's a ligament attach?
Bone to bone.
Bone to bone. So tendon is this a ribbon or this fibrous, strong white bands that attach muscles to bone. And we could have another example of some tendinous attachment is known as an aponeurosis. So where tendons can't attach directly to bone, or there's not a lot of bone to attach to, such as the abs, right? Such as Joe's abs, because he's got these massive 8-pack, it's not a 6-pack.
Yeah.
It's an 8-pack.
That's my lab partner,
Right?
let's go.
And these abdominal muscles all attach to something known as a linea alba. And this linea alba is this tendinous attachment, because there's not a lot of bones that's gonna attach to. I mean, we have attachment from xiphoid process to pubic symphysis, you know? And then we have to have, it has to attach somewhere in between. So we have this tendinous sheath known as an aponeurosis. We also have it on the posterior part of our bodies, or the dorsal part of our bodies with the latissimus. Because the latissimus is a huge muscle. Latissimus runs from the iliac crest, the lumbar vertebra, the iliolumbar ligament, goes to the angle of the scapula, as well as the last couple ribs and the last few lumbar vertebra, and then go into the shoulder. So it has to have somewhere to attach in it as it goes. So we have these tendinous attachment, or these aponeuroses, okay? Fascia, I said fascia is everywhere. Fascia is this attachment, or this covering that separates muscles and also encloses them. So when we talk about joint structure and cartilage, we talk about different types of cartilage. We've already mentioned hyaline cartilage, and that's actually just at the end of these opposing bones, or these long bones, and other bones too. It's a smooth articular surface. Hyaline cartilage is thought to have no blood supply and no nerve supply. Therefore, it gets all its nutrition from synovial fluid. So it provides this smooth surface. Fibrocartilage is the strongest cartilage we have. Strongest cartilage we have, so where do you think we have it? In places we're most vulnerable. So fibrocartilage, we see fibrocartilaginous disc in the intervertebral discs. We see it in the knee, the menisci of the knee. We see it between, if you look at your hand and you look at the ulna and you look at the carpal bones, there's a space. That space is filled with fibrocartilaginous disc because we fall on outstretched hands. It's also between the sternum and the clavicle. The SC joint prevents dislocation of the clavicle right into the sternum. So we have that. Let's see. Elastic cartilage. Elastic cartilage helps just for the structure to maintain its shape. And there's a certain amount of motion allowed with elastic cartilage, and we mentioned the pubic symphysis. We also said that there's elastic cartilage in the ear, I think, the eustachian tube, I think we said that. But that's where we have in the larynx. Skeletal pathologies, and I'll finish on this page. Skeletal pathologies that we'll talk about right now, we'll talk about basic ones. If we have a simple fracture, it's just a bone breaks. We can correct a simple fracture with a cast. Okay, we don't need to do surgical intervention with a simple fracture. So the physician x-rays, he aligns, he casts, he sends you on your way. Compound fractures when the bone comes through the skin. Okay, what do we worry about when we have compound fractures? Infections. Okay, do not, if you see somebody laying on the ground and you see part of their femur sticking out, attempt to push it back in. Okay, that is not something you want to do. Leave it out there, cover it, make sure everything is clean, get that person in ASAP. Green stick fracture is a fracture of a child. It's kind of like, it's known as an incomplete fracture. It's not a complete fracture. It happens with children. It's like a twig. You guys know what I'm talking about when you talk about a twig of a tree. You take a big branch on a tree, you try to break it, it cracks, right? You have two pieces, one here, one here. You take a twig, you break it, it breaks on one side, but the integrity of the twig is still there on the other side. That's known as a green stick fracture, and that's also known as an incomplete fracture. Okay. Comminuted fracture is when it breaks into a lot of pieces, or as opposed to an impacted fracture where, as I said, I worked in inner city hospital when they used to have windows that opened, and I once worked with a prisoner that jumped out the window. He jumped out the window on a 3-story floor. If I would have jumped, I probably would have died, but he was lucky enough to just have an impacted calcaneal fracture. And then he started running. But they caught him because he couldn't run too well. But that's an impact calcaneal fracture. One bone goes into the other. Okay? You could have a double break, multi-fracture, spiral fracture. Spiral fractures, if they happen in children, and they happen many, many times, and you're the one working with you're a pediatric therapist, and you're working with this patient. Can I have your hand, Joe?
Yeah.
Okay. These are usually what can I have your right hand because I'm right-handed? These are usually what spiral fractures come from. You see me twist and pull them? So I'm walking down the street with my child, and I say, come on, let's go. Come on, come with me. Or I say, you're not doing what you should. Get over there. So I'm twisting, it's that spiral effect, and this is a young growing bone. And I'm putting a torsional torque on that and pulling it and fracturing it. So if this is occurring multiple times, I need to report it to someone. Okay? Spiral fracture. All right, finally, I know somebody's leaving, so skeletal pathologies, osteoporosis. Osteoporosis is a loss of bone density, and that can lead to a pathological fracture. The definition of a pathological fracture is one that occurs secondary to a disease process. Okay? So you could have a pathological fracture because you have cancer. All right, the bones become weak, you have metastasis, they start to fracture. I have a patient that had a pathological fracture. I was seeing her for a knee, she was complaining of her back. I asked her what she did on the weekend, nothing. I hung out with the girls, I went to the country club. What did you do? I play golf. So what did she do? She fractured her thoracic spine. Okay, pathological fracture, osteoporosis, yes.
I forget if it was you or Dr. Maley that mentioned about the someone who had a, I think it was Dr. Maley mentioned about a patient who had cancer, some sort of sarcoma. And
Yes.
literally just they were probing and it literally broke
Yes.
through. So that would be a pathological fracture as well.
Well, that.
Well, I mean, but for the
yeah.
probing motion, but
Well,
it's-
that wasn't even, his bone just dissolved. That wasn't a fracture. A fracture is just a break, right? So you could have a break secondary. I know you guys are going, so we'll finish this Tuesday.
If the labs are open, can we go practice transfers?
The labs, you can only practice in the lab when there is faculty or there is someone here.
Okay.
As I said to Ashka, because of what's happening now with COVID, we have to know at least a week in advance, and we
Okay.
have to know your names, and we have to provide that to security, and we have to make sure someone is here.
So can we email you